Hi everyone, I am Dr. Ramya, MDS in the Department of Periodontics. The topic I want to discuss is about the radiographic aids in periodontics. The reason why I chose this topic is radiographs are something which we prescribe usually on a regular basis, isn't it? But are we actually sure or are we actually able to justify a prescription for radiographs? Do we actually know when to prescribe the radiographs and when not to prescribe the radiographs? So this is the main motto of my presentation, along with the discussion about the normal features and the diseased features, how they appear on the radiographs, along with the conventional and advanced imaging modalities. So let's get started. So radiographs play an integral role in the assessment of the periodontal disease. So starting with the diagnosis and later the estimation of the severity of the disease, and next the determination of prognosis, and finally for the purpose of treatment, and even after the treatment is completed, for the evaluation of the treatment outcome, we are using the radiographs, right? But I want to emphasize an important point here. Not all conditions require radiographs. Radiographs should be taken based on specific situations. We should not take radiographs by policy. Okay, so clinical examination is always the gold standard. So along with the clinical examination, historic findings that are provided by the patient along with the radiographs if necessary form the diagnostic workup. So radiographs form only one of the element of the diagnostic workup, but they are not a substitute to the clinical examination. They are always adjunct to the clinical examination but not substitute to the clinical examination. And radiographs always provide information about the destruction that has taken place in the past. They will only help us know about the past cellular activity, but they do not reveal about the current cellular activity. So before getting into the features that appear in case of periodontal disease, we will start with the normal anatomy. So the alveolar bone appears parallel to the cemento-enamel junction. So here you can see a white lining on the alveolar crest. This is the cortical lining. This cortical lining may be present, sometimes it may not be present, okay? But this crest, the height of the crest is about 0.5 to 2 mm below the cemento-enamel junction. So this is the level at which the alveolar crest is present. So we are taking this height from the cemento-enamel junction, and this alveolar crest is parallel to the line joining the two cemento-enamel junctions. So in case of posterior teeth, it is flat and smooth. It is covered by thin white line only sometimes. Even if this white line is not present, it is not pathologic. Okay. If the white line is not present, you need to consider the level and the density of the alveolar bone. What is the level? We have already seen that the level is 0.5 to 2 mm below the cemento-enamel junction. So if this level is normal and if the density of the bone is normal, then it is not pathologic. And remember that the lamina dura, which is the lining around the tooth root structure, forms a right angle with the alveolar crest. If there is rounding of this angle, then it is considered as pathology. Okay. In the anterior teeth, this alveolar crest appears pointed, okay, and there is well-defined cortical bone. This cortical bone, it's a dense bone and it is in continuation with the lamina dura that surrounds the tooth sockets. So this is the point we have already discussed. The presence of cortical lining definitely indicates absence of disease. Yes, if there is cortical lining, we say that the disease is not present. But if it is absent, then even if it is absent also, it does not indicate that disease is present. If the level and the density of the bone are normal, then the presence or absence of cortical line will not matter. Okay. So next, in this radiographic picture, we can see the rounding of the angle in between the lamina dura and the alveolar crest. So there is no right angle in between the alveolar crest and the lamina dura. So there is rounding of the angle indicating the pathology. Okay, here you can see some deposits in the interproximal area. What are these deposits? These are the calicularis deposits which are appearing as interproximal spurs. Okay. Next, here you can see pronounced bone loss in the furcation region. Next. So, evaluation of the periodontal disease is mainly based on the appearance of interdental bone. Why? We have the facial bone, we have the lingual bone, we have the interproximal bone. But why are we basing our evaluation only on the presence of interdental bone? So, remember an important concept. So, if this is tooth, it is covered by the facial bone and it is covered by the lingual bone and it is covered by the interdental bone in between the two teeth, right? So, there is facial bone Here it is interdental bone, that is a bone that is present in between the two teeth. What happens is the roots of the teeth are radiodense. They are more radiodense when compared to the facial or lingual cortical plates. So they are masking the appearance of these facial and lingual cortical plates. That is why we are not able to appreciate the facial and lingual cortical plates on the radiograph. That is why we are basing our diagnosis mainly on the appearance of this interdental bone. Okay. Next, if suppose there is difference in between the levels of CEJ, the alveolar crest appears angulated. See in this picture, if suppose these CEJs are at the same level, then obviously the alveolar crest will also be parallel to the line connecting CEJs. So these CEJs are at different levels. You can see in this picture, then obviously this alveolar crest is angulated. Okay, does not appear flat. Next, we'll see how periodontal ligament appears. So this periodontal ligament is a space in between the lamina dura and the tooth root. Okay. This periodontal space differs from one person to other person, and within the same individual it is same if there is no pathology. Okay, within an individual this periodontal ligament space is uniform. If suppose there is disease present in case of a particular tooth, then the periodontal membrane space differs from one tooth to other tooth in the same person. Okay. Whereas in case of erupting teeth, the periodontal ligament space is wide, especially in the cervical region of the tooth. Next, we'll talk about nutrient canals. So, if nutrient canals are present, if nutrient canals are more in number, then it means that active bone resorption is going on. So, these nutrient canals are linear and circular areas. Okay. So these are linear and circular areas which usually appear in the anterior mandibular region. They might be present even throughout the reach, but most commonly they are seen in the anterior mandible. Okay, but if nutrient canals are present, it is one of the features wherein we can say that the bone resorption is going on in an active manner. Next, we will come to the features that are seen in case of periodontal disease. So there might be changes in the morphology, there might be changes in the density. So if suppose there are changes in the morphology, where do they take place? They take place on the facial bone or the lingual bone or on the interdental bone, that is the bone in between the two teeth. If suppose there are changes in the internal density, what might happen? There might be increase in the density or there might be decrease in the density of the bone. Okay, so now we will talk about early bone loss. Does early bone loss appear on radiographs? No, early bone loss does not appear on the radiographs. So when the bone loss is just starting, sufficient mineralized tissue or sufficient calcified tissue is not removed at that stage. So we cannot appreciate early bone loss on radiographs. But if we are noticing slight radiographic changes, it means that the early stage is already crossed. Okay, that is why we are able to appreciate such changes on radiogram. So remember that it takes around 6 to 8 months of destruction in order for us to see the radiographic change. So if you are seeing the slight radiographic changes, it means that it is beyond the early stage. The progression has crossed the early stage. So how do you know that the bone loss is occurring? So there will be localized erosion of the interproximal alveolar crest. Remember, I told there is a sharp angle in between the alveolar crest and lamina dura. So this sharp angle is lost. There will be irregular border of the alveolar bone. So Glickman has stated 3 early bone changes. The first one is the crestal irregularity. So here you can see the irregular alveolar bone, irregular and rough alveolar bone, and there is also the loss of the sharp angle in between the alveolar crest and the lamina dura. Next, we will see the triangulation. So here the periodontal ligament space gets widened. Okay. So it appears like a triangle with the base of the triangle towards the crown surface. So there will be widening of the periodontal ligament which appears as a triangle. So this particular feature is called as triangulation, in which there is widening of the periodontal ligament. There will be finger-like projections. These finger-like projections are because of the extension of the inflammation from the gingiva into the alveolar bone. So the inflammation which is present in the gingiva has extended into the alveolar bone. There is widening of the blood vessels, because of which we will see these finger-like projections. Next, we will see about the different patterns of bone loss. So this bone loss might be seen in a horizontal manner, vertical manner, or there might be crater-like defects which we will be seeing later, or there will be buccal or lingual cortical plate loss. So simple, there might be loss in the buccal plate, there might be loss in the lingual plate, or there might be loss in the interproximal area which might be horizontal or vertical, or there might be specific bone loss in the furcation regions. So here we come to the horizontal pattern. So the crest of the bone is horizontal, okay, or it is at right angles to the long axis of the tooth. So as the name suggests, the bone loss, the pattern is horizontal, okay. Next is a vertical bone loss. So here there is an oblique angulation of the alveolar crest. If suppose you draw a line that is connecting the two CEJs, the angle in between the alveolar crest and the line joining two CEJs is oblique. Okay, so this is known as vertical or angular or arcuate pattern of bone loss. Next we will come to craters. So craters are the defects which are present in between intact facial and lingual plates. So here you can see the normal alveolar bone morphology, but here you can see that there is intact facial plate, intact lingual plate, but in between there is loss of bone. This particular defect is called as crater. Do you think we can appreciate this on radiographs? No, we cannot appreciate because the intact facial and lingual plates are masking the defect in between. So we cannot appreciate craters on the radiographs. Next, sometimes what happens, you think that there's a bone loss in the interproximal region. But what happens is this vertical bone loss in the interproximal region might extend onto the facial or lingual cortical plates resembling a trough. Okay, so here you see a vertical bone loss. So this vertical bone loss might usually extend onto the facial or lingual plates, creating a trough like this. Okay. Next, buccal or lingual cortical plate loss. So usually we cannot appreciate this, especially on the two-dimensional radiographs, because we have already learned about a concept, that is the root structure is more radio dense when compared to the buccal or lingual cortical plate. So because of the more higher radio density of the tooth root, we are not able to appreciate the buccal or lingual cortical plate loss. But this buccal or lingual cortical plate loss sometimes appears alone, or it might appear along with the loss of the interproximal bone also. So this you can appreciate a semicircular area, okay, with the radiolucency directed apically. The apex of the radiolucency is towards the apical region. So here you can see the isolated buccal cortical plate loss. Okay. Next, furcation involvement. The best way to diagnose furcation is clinical examination and surgical exploration of the defect. If you open the defect, then you will be able to better know the furcation defect. This is because radiographs are useful to diagnose furcation, but sometimes what happens is there will be superimposition of the roots. Because of this superimposition, especially in case of maxillary molar, wherein there are three roots, there will be superimposition. If suppose you take a radiograph, you might be missing the furcation involvement. That is why always remember, in order to not miss the furcation involvement, we need to take the radiographs in different angulations. Okay, so there might be involvement in one film, involvement in other film. So in order to not miss the furcation involvement, we need to take the radiographs in different angles. So here you can see the bone loss in the furcation area. So remember, if suppose there is decrease in the radio density in the particular area, or if there is isolated bone loss in a molar tooth, then you can suspect a furcation involvement. So here in this picture, you can see an inverted J shadow, which is seen in the furcation involvement areas. Next, periodontal abscess. See, radiographic picture of periodontal abscess is not always characteristic. It is not always necessary that radiographic changes have to be present. It depends on the stage of the lesion. If suppose it is an early stage, it has only involved the soft tissue, then obviously there won't be any radiographic change. If it is involving the bone, if the destruction has taken place to a certain extent, then only we can appreciate the radiographic change. So here you can see the destruction. So there is bone loss apically, but there is some bridge of bone, there is some bone in the coronal region. But this radiographic picture is not always characteristic. It is not necessary that All the periodontal abscess cases will have such radiographic picture. It depends on the stage of the lesion and the amount of destruction that is taken place. Next, we will get into the radiographic picture of localized aggressive periodontitis. So here I want to add an important point. In 2017, periodontal and peri-implant diseases and conditions, the classification, the recent classification which was given has removed the terminology of chronic periodontitis and aggressive periodontitis. Currently, there is only one term, that is periodontitis. Okay, we don't have chronic periodontitis or aggressive periodontitis. But this, why I have mentioned this is according to the previous terminology. So this localized aggressive periodontitis, which involves the maxillary and mandibular, incisor and first molar areas, this localized areas will have a vertical arc-like destructive pattern. So we'll see in this picture. So this is the arc-like destructive pattern, and usually in this localized aggressive periodontitis cases, this pattern is bilaterally symmetrical. Okay. Next, in trauma from occlusion, there will be thickness of the lamina dura, increase in the thickness of lamina dura, there will be widening of the periodontal ligament space. So as the occlusion forces are increased, then obviously the width of the periodontal ligament will increase. There will be increase in the number and size of the trabeculae. Next, in case of tooth mobility, it is not necessary that the widening of PDL has to be present in case of tooth mobility, but in case of single rooted teeth, there will be hourglass shape. And open contacts can also be seen in radiographs. Local irritating factors like calculus can also be noted on radiographs, or else the overhanging restoration margins. But an important point is that these open contacts and local irritating factors can even be appreciated clinically also. So for those findings which can be appreciated clinically, we need not take radiographs again. Okay. So, when do we know? Can we know if the destruction that is going on is active or passive? If suppose the crest of the alveolar bone is irregular and there are more amount of nutrient canals, we can say that the destruction that is going on is active. If suppose the alveolar crest is smooth, then we can say that the destruction that is going on is static or passive. Okay. Next, we have seen the changes that occur in the morphology, wherein we have seen about the horizontal pattern, vertical pattern, the craters, furcation involvement. Next, we'll see the changes that occur in the density. So there might be decrease in the density or increase in the density. Because of these periodontal lesions, they will stimulate some reaction in the surrounding bone also, whatever the bone that is present surrounding that. So because of this, there might be deposition of the bone or the loss of the bone. So sometimes there might be mixture of both the deposition and the loss of the bone, which will be affecting the density. Next, this is very important. What are the periodontal findings that are captured on radiographs that are not captured on radiographs? So all the soft tissue findings are not captured on radiographs. Isn't it? Soft tissue findings cannot appear on the radiographs, right? So gingival redness, swelling, bleeding, probing pocket depths, suppuration cannot appear on the radiographs. Whereas some findings that lead to the periodontal disease. So these are the findings that are related to the predisposition of the periodontal disease. What do we mean by predisposition? So studies have stated that if these findings are present, they might lead to periodontal disease. Like if calculus is present, or if overhanging restorations are present, or if there are any root anomalies. So if these findings are present, it might lead to periodontal disease. So these findings can be appreciated on radiographs, but remember that calculus and overhanging restoration margins can be appreciated clinically. So in order to prove that, again, you need not take radiographs. Radiographs should not be taken by policy. Radiographs should be taken only in cases where you need. Next, we will get into the technical aspects. So the quality of the radiograph that we are taking depends on several factors like the speed of the film or the kilovoltage. Okay, so we are using E-speed films in dentistry, right? We use E-speed films, but the D-speed films have greater detail. We can appreciate greater detail in D-speed films when compared to E-speed films. But even though we know this fact, why are we using E-speed films in dentistry? That is because E-speed films have low radiation exposure when compared to D-speed films. And when studies were conducted to compare the appreciation of the details in E-speed films and E-speed films, there was not much difference noted in between these two films. And also the E-speed films have low radiation exposure. So that is the reason why we use E-speed films in dentistry. And when coming to high kilovoltage, there will be high kilovoltage and low kilovoltage. So this high kilovoltage means 90 kVp, whereas low kilovoltage means 60 to 70 kVp. So this low kilovoltage means there will be more absorption into the tissues. So it is harmful. Whereas high kilovoltage, there will be less absorption into the tissues and more appreciation of the details. So in order to improve the clinical radiographs in periodontics, we use vertical Bitewing films. I'll talk about this later. We will be using the 90 kVp films as there will be decreased radiation dose to the tissues and also increased gray level information, that is increased appreciation of the details. And in periodontics, in order to detect whether the bone loss is taking place or the bone formation is taking place. In order to detect the bone changes, we will be using the millimeter grid and the root length ruler, which we'll be talking later again. Next, we have some criteria called as Pritchard's criteria. So Pritchard has given some criteria for an ideal radiograph. So an ideal radiograph should show the tips of the molar cusps, whereas it should not show the occlusal surface. The occlusal surface should not be shown, only the tips of the molar cusp should be shown, and there should be distinct visibility of the enamel caps and the pulp chambers. The interproximal spaces should be open. There should not be overlapping in between the two teeth. So here in this picture you can notice the overlapping of the interproximal spaces. No, it should not appear like that. Okay. Next, we will see about the conventional imaging modalities. In this, we have the periapical radiographs, Bitewing radiographs, and the panoramic radiographs, wherein the periapical radiographs and the Bitewing radiographs are most commonly used. But the periapical radiographs are even more frequently used when compared to Bitewing radiographs. But the periapical radiographs do not actually reveal the relationship, exact relationship in between the cemento-enamel junction and the alveolar bone. If periapical radiographs have to be used in order to obtain the proper information, we need to use the paralleling angle technique. The Bitewing radiographs are often considered as the forgotten radiographs. We are not using the vertical Bitewings usually in the regular practice, but vertical Bitewings are best when there is severe bone loss. Okay, horizontal Bitewings are used in order to diagnose the carious lesions, whereas the vertical Bitewings can be used when there is severe bone loss, but vertical Bitewings are not being used. But periapical radiographs should be used with a paralleling angle technique. If suppose in cases of shallow palate and floor of the mouth, placement of the film becomes difficult, placement of the periapical film becomes difficult. In such cases, we can use the Bitewing radiography. Okay. Next, so this is the periapical film radiography. This is the Bitewing radiography. So this is the paralleling angle technique in which the central ray is perpendicular both to the tooth as well as the image receptor. So paralleling angle technique produces the correct relationship in between alveolar bone and CJ when used along with the periapical radiography. Whereas this is the bisecting angle technique in which the central ray is perpendicular to the bisector line. Okay. So this imaginary bisector is the one. So it forms an angle both with the central axis of the tooth as well as with the image receptor. So the central ray is perpendicular to this bisector. It is not perpendicular to both the tooth as well as the image receptor, which we have seen in the paralleling angle technique. So next we'll see about the Bitewing projections. So Bitewing projections, as I've already told you, they are considered as a forgotten radiograph, but they are the preferred imaging technique in order to depict the periodontal bone levels in the posterior dentition. So if the periodontal bone loss is severe, you have to consider the Bitewing radiographs. Okay. Next, we'll come to the panoramic radiography. What do we all know about the panoramic radiography? Panoramic radiograph gives an overall view of the dentition, isn't it? It gives an overall view, like what are all the problems present in the dentition. But it is considered to be of little diagnostic value because we usually see that the periapical radiographs give us more detail when compared to the panoramic radiograph. But this is not actually true. When studies were conducted comparing both the periapical radiographs and the panoramic radiographs, they did not find any difference. Okay, the details that are seen in the periapicals are also appreciated on the panoramic radiographs. This is what studies say. But depending on the level of experience, this version differs. That means because of the clinician's level of experience, he might find that the panoramic radiograph and the periapical radiograph give the same details. But in some clinicians with a low level of experience, they might feel that periapical radiographs are giving better detail when compared to panoramic radiograph. An important point here is panoramic radiographs have the less radiation exposure when compared to the periapical radiographs. So there is something called as gold standard radiation exposure. If suppose the patient is having a panoramic radiograph, patient has come to you with already taken panoramic radiograph, then if you take less than 4 periapical radiographs in the selected regions, then it is considered as a gold standard for radiation exposure. If suppose you take 7 periapical radiographs along with a panoramic radiograph, then you have exceeded the radiation dose. Remember that. So the gold standard for radiation exposure is panoramic radiograph along with the less than 4 periapicals. Whereas if you take both the panoramic radiograph as well as 7 periapical radiographs, you have exceeded the radiation exposure. So this is what studies say. So what all you can appreciate on the periapical radiographs are even appreciated on the panoramic radiographs. It depends on the level of the clinician's experience in order to identify what the findings seen on the panoramic radiograph. So this is how a panoramic radiograph looks like. So it will give us an overall view of the dentition. Okay. So an important point here and an interesting point I found. So AAP, the American Academy of Periodontology, states that there should always be some record of what was found on radiographs. Okay, there should be a handwritten record of findings. How many of us are doing this, right? So AAP states that there should always be a record of the findings that you have detected on the radiographs. So usually the full mouth series of periapicals we take should be viewed on a clear background, not on a black background, and we should use a light box. So this light box is something, it's a viewing box. Okay, this is the viewing box of the light box, which has an inbuilt magnifying lens. So which helps us in appreciating the bone levels in a better way. We will be able to better appreciate the alveolar bone levels. So this process should be done in a darkened or semi-darkened room, and this periapical film should be placed. Periapical or even panoramic radiographs are placed on a clear background. With the help of viewing box, we will view the radiograph. So yeah, the interesting point comes here. When to prescribe the radiographs? So the US Department of Health and Human Services in 1987 has stated that radiographs should not be taken by policy. You should take only when radiographs are needed. So this is called as justification. Okay. So this was what I was talking in the introduction. So are we really able to justify our prescription for radiographs? Justification is something which makes a difference. If suppose you are prescribing a radiograph to a patient, you are not prescribing a radiograph to a patient. Okay, if there is really a difference between your prescription, if suppose there is a change in the treatment plan with your prescription, then that is called as justification. You should always justify your prescription. If there is really a difference that you can see, then only you need to prescribe the radiographs. Okay. So when to prescribe the radiographs? In case of gingival diseases, it is not required. In case of chronic periodontitis, it is not required. Aggressive periodontitis, it is not required. But sequential radiographs will display the rapid bone loss that is taking place in this condition. In case of necrotizing periodontal disease, abscesses, we do not require radiographs. But in case of periodontitis associated with endodontic lesion, that is endoperioral lesions, it is required especially for the endodontic diagnosis. In case of developmental or acquired deformities, we will be requiring the periapicals of the selected regions, or radiographs of the selected regions. Okay. Yes, this is an interesting point. That is the diagnostic yield and the therapeutic yield. So a study was conducted in which around 332 individuals have participated. In this study, what they have done is they have diagnosed the patients and they have given a particular diagnosis, okay, before taking radiographs. And after that, they have prescribed the radiographs to the patient and they have again noted the diagnosis. what they have found is there was no difference in the diagnosis even before prescribing the radiograph and after prescribing the radiographs. So there is no diagnostic yield. We do not have any difference in the diagnosis. Even though the radiographs were prescribed or not prescribed, also the diagnosis was same. There was no diagnostic yield. That means there was not much difference. Okay. But when the treatment plans were framed before prescribing radiographs and after prescribing radiographs, there was therapeutic yield. That means there was change in the treatment plans before prescribing the radiograph and after prescribing the radiograph. This is called as therapeutic yield. This study stated that the radiographs are used or should be used for the therapeutic yield, for the change in your treatment. If you really think that prescribing radiographs will change your treatment plan, then only you should advise radiographs. Okay, it is not for confirming your diagnosis that you prescribe radiograph. When you already know, it's no need to confirm the diagnosis by your radiographs. If you really think there will be a change in your treatment plan, if you prescribe the radiographs, then only you should prescribe the radiograph. So this is the diagnostic yield and therapeutic yield. So this is nothing but the justification for your radiographs. If you really find a difference on prescribing radiographs, then you should prescribe radiographs. Okay. Next, I want to talk about the major misconceptions about radiographs. So we often blame radiographs. In what way? So we often think that radiographs do not show the disease in an early stage. Okay, so we say that around 30 to 50% of bone loss should occur in order for us to see it on the radiographs. So even I have said in the beginning slides that if you are seeing the bone loss on the radiograph, it means that the early stage has crossed. And I also stated that early bone loss does not appear on radiographs, right? It is not captured on radiographs. But Jeff Cote is the author who stated that it is not problem with the radiographs, but it is a problem with the clinician's eye. The clinician's eye is not able to appreciate what the radiograph is showing. So he stated that if we use digital radiography, digital intraoral radiography, or if we use some additional imaging modalities, we will be able to better appreciate the early bone loss. So we are not using the proper imaging modalities and we are blaming the radiographs to be the late indicators of the disease. So this is what Jeff Cote has told in his article. Another one is, we state that large changes in probing attachment level may occur in the absence of radiographs. That means we state that even though there are large probing depths, this change is not noted in the radiographs. So this is also false. Jeff Cote has stated that it is not a problem with the radiographs, but it is a problem with the clinician's eye, which is not able to appreciate the details that are seen on the radiographs. So he states that better imaging modalities, especially digital intraoral radiography, in which you can zoom in and zoom out or adjust the contrast and brightness, will help us in better appreciating the details. And we also say that there will be variations in brightness and contrast that will result in the crest burnout. So this is with the processing difficulties. So in case of digital intraoral radiography, we don't have the processing difficulties, right? So this digital intraoral radiography avoids the processing difficulties and we can easily adjust the contrast and brightness of the pictures. We can zoom in and zoom out. We can easily appreciate the changes that are shown on radiographs. We'll come to the uses of radiographs. So radiographs tell us about the amount of bone present, condition of the alveolar crest, bone loss in the furcation areas. And here is an important point. These are the uses of radiographs that they help us in detecting the local irritating factors, calculus and overextended restorations. But if we see them clinically, if we are able to appreciate them clinically, what is the need for prescribing the radiographs? It is an unnecessary prescription for radiographs. So for these factors, in order to confirm these factors, you should never prescribe radiographs. So in case of open interproximal contacts, which are the sites for the foot impaction, we can prescribe the radiographs. Or in case of implant placement, wherein you want to know the position of the maxillary sinus, you can prescribe the radiographs. In case of caries, periapical lesions, we can use the radiographs. Okay, what are the limitations? Radiographs provide a two-dimensional view of a three-dimensional situation, right? The three-dimensional situation we are trying to view in a two-dimensional view, right? So that is the limitation. And next, in case of severe bone destruction, the radiographs will show less bone destruction. So this is what we are calling it as late indicator, but however, according to Jeff Cote, this is a misconception. And radiographs also demonstrate any relationship in between the soft tissue and hard tissue. and the condition of gingiva cannot be predicted. And see, we are measuring the bone level with the help of the cemento-enamel junction. That is the cemento-enamel junction. We are taking it as a mark. But if suppose there is over-eruption, if suppose there is severe attrition, or wherein we cannot appreciate the cemento-enamel junction position, in such cases, the bone level measurement is not valid. Okay, in cases of over-eruption or passive eruption and severe attrition. And important thing, the radiographs will not help us differentiate in between the successfully treated cases and untreated cases. We will not know, like even the patient has undergone treatment from other clinician or anywhere, and if he gets a radiograph, we will not be able to differentiate whether he has undergone a treatment or not. Radiographs do not show difference in between treated cases and untreated cases. Okay. So we will know something called as standardization of radiographs. So standardization is taking radiographs in a similar way every time, in a similar manner every time. So it is not always possible to take radiographs in a same way every time, right? So for that, we have these parallel positioning devices or positioning rods. Okay, so these will help us in standardization of radiographs. So next we'll get into the advanced imaging modalities. The first one is digital intraoral radiography. So this is what we see in the clinics, usually. So digital intraoral radiography, it will have a sensor. It is computerized. It is a filmless radiography. We do not have to process the films, because there is no need of film only. It is called as filmless radiography. And with the help of digital intraoral radiography, we will be able to zoom in and zoom out the pictures. We will be able to adjust the contrast and brightness. So it will help us in better appreciation of the details. Okay, and this digital intraoral radiography helps us in saving the images. We can even print the images. It will help us in tele-diagnosis. Okay, the next one is a digital subtraction radiography, that is the DSR. We'll talk about it later. Next one is a cone beam computed tomography. So here in this picture you can see a handheld X-ray machine. So this is useful for patients in remote areas. When you go for some surveys or studies, you can carry this in order to take the radiographs. So this is the digital radiography picture. Okay, so it will have some options. So it is computerized. It will have the options wherein you can adjust the contrast and brightness and whatever you want. Yeah, this is the digital subtraction radiography. So this digital subtraction radiography, the main advantage is that it will detect even the small amounts of bone changes. But the main disadvantage with this is digital subtraction radiography images have to be taken in similar manner every time. You have to take serial radiographs, and these serial radiographs have to be taken in a similar way every time. So when you superimpose all these radiographs, whatever you're taking in a serial manner, when you superimpose these, you will get the image like this. So here you can see this is the initial image and this is after 3 months. So when you superimpose, you are seeing that there is bone loss in this particular region. Okay, so subtraction radiography, it will help us know whether the bone has formed or the bone loss has occurred. In case of digital subtraction radiography, another important thing is custom bite blocks of the patient have to be saved every time. So in order to take the radiographs every time in a similar manner, we will be using the bite blocks. So all the bite blocks of the patient have to be preserved for a longer time, right? In order to take the radiograph in a similar way, we need to preserve the bite blocks. And also, one author called as Mole, he stated that even though this DSR, that is the digital subtraction radiography, detects a minute amounts of bone changes, what is the use if we are not able to appreciate that clinically? I hope you got my point. So clinically, the patient is not experiencing anything, or we are not able to appreciate anything. But the digital subtraction radiography is detecting even minute amounts of bone loss. So what is the use of digital subtraction radiography? There should be some price, right? So we are putting a high price on this machine. We are putting a high price. We are taking a lot of effort. Not only in the in case of cost, we are putting a lot of effort in taking all these serial images. We are saving, we are preserving all these bite blocks. But even if it detects minute amounts, what is the use? We are not able to appreciate that clinically, right? So that was what Moll stated. Okay. So next is CBCT. The CBCT avoids the problems of superimposition and unpredictable magnification. So it depicts both the buccal, lingual and palatal surface. This will have improved the morphology of the defect. You can visualize the defect in a proper way, but not all conditions we advise CBCT. CBCT usually we prescribe for patients who want to undergo implants. Okay. So this is the CBCT software, okay, wherein you have all these windows in which you can zoom in and zoom out and view whatever region you want. Okay, so this is the CBCT software. And this CBCT software also helps us in placement of implants, like planning the placement of implants. You can select the implant dimension you want, you can place it, you can just check. Okay, so it will help us also in planning the position of the implants. So yeah, radiology in support of periodontal therapy. So once the patient's treatment is completed, you need to take the radiographs at particular intervals. If suppose the patient is having a high risk factors for caries, then posterior bitewings have to be taken for every 6 to 8 month interval. Now I'll go to the periodontal part. Yeah. If the patient is having periodontal disease and it is not under good control, the periapicals or vertical bitewings have to be taken in the problem areas every 12 to 24 months. If the patient is already having a history of periodontal treatment, but now the disease is under good control, then bitewings have to be taken for every 24 to 36 months. Next, in case of implants, root form dental implants are placed. So for every 12 to 24 months, and then unless the problem arises, you should not take later, and if there is no problem, you have to take again at 24 to 36 months intervals. Okay. Yeah, radiology in implants. Why do we prescribe radiographs in case of implant patients? So in case of wide residual ridges, if the ridge is wider, then only visual examination or palpation of the ridge or even the panoramic radiography will be sufficient. Okay, so in cases where the ridges are compromised, wherein we have the compromised conditions wherein we need more treatment planning, in such cases we will be advising the advanced radiography techniques like CBCT, CT. Okay. So in the initial examination, panoramic radiographs supplemented by some few periapical radiographs would be sufficient. Cross-sectional imaging like CBCT is not appropriate for initial examination. In case of preoperative conditions, site-specific imaging has to be done. If you really need to assess the bone reconstruction or augmentation procedures in order to assess those procedures, you can take CBCT. And post-operative, if the implants are asymptomatic, intraoral periapical radiographs or panoramic. If the case is extensive, you can advise CBCT. Okay. In case if there is implant mobility, cross-sectional imaging like CBCT can be taken. If there is implant retrieval, if you're supposing that the implant is retrieving, so in such cases, cross-sectional imaging like CBCT can be done. Okay. So this is the implant planning which I have talked about. You can select the implant dimensions you want, and you can plan the implant placement. Yeah, let's get into the conclusion of the topic. The periapical radiographic examination should be a part of every patient's periodontal evaluation, coupled with a detailed recording of pocket depths, gingival margin location, and bleeding on profile. So the radiographic evaluation should be updated every 2 years. Periapical radiographs often underestimate the amount of periodontal bone loss, and early bone changes are usually not detected. So periapical radiographs are underestimating. Then we have to take the vertical bitewings in case of severe bone loss. So the main takeover points from my discussion is the periapical radiographs do not estimate the correct position in between the correct relationship in between the alveolar bone and the cemento-enamel junction. You need to take vertical bitewings. You need to know when to prescribe the radiographs, in what conditions you need to prescribe the radiographs. I want you all to understand and remember the points of diagnostic yield and therapeutic yield. If there is really therapeutic yield, if it is really a justification for your prescription, then only you need to prescribe the radiograph. You need to understand the radiology, the pattern, the regular intervals that has to be followed for taking radiographs in supportive periodontal therapy. Thank you everyone for your patient listening.